Welcome to another pediatric physical examination lesson. In my today's lesson, I'm going to talk about examination of the cardiovascular system in pediatrics. Just to mention some symptoms of cardiovascular problems that occurs in children before going into deeply explaining the physical examination of the cardiovascular system in pediatrics. There are different symptoms, most of them non-specific, that shows a child has a cardiovascular problem. From this, tachycardia, tachypnea, body swelling or edema, tiredness or fatigue, and also rapid breathing during feeding or feeding interruption, cyanosis, failure to gain weight or failure to thrive, chest pain or shortness of breath or dyspnea, orthopnea or paroxysmal nocturnal dyspnea, palpitation, and hemoptysis those are the most common symptoms that patient with cardiovascular problem experience. When we came to the specific examination of the cardiovascular system, it includes peripheral signs of cardiac disease or heart disease, blood pressure, pulse rate, arterial system examination, jugular venous pressure, and the precordium. So examination of the cardiovascular system consists peripheral signs of heart disease. We should have to check for peripheral signs of cardiac disease. We should have to measure blood pressure. We should have to measure pulse rate. We should have to measure. We should have to check arterial system, and we should have to also measure jugular venous pressure, and also we should have to examine the precordium. When we see the peripheral signs that suggest heart disease, majority of them are not specific for cardiovascular problem, but they are seen in a patient who have a cardiovascular problem. From this, clubbing, cyanosis is most of the time seen in the inner surface of the lower lips or lower surface of the tongue and fingertips. And signs of anemia, check for pallor on conjunctiva, the tongue, palm, and the sole. And also check for edema on the dependent area such as pedal, pretibial, and sacral area. These are non-specific signs that shows there is cardiac disease, but they are not specific for heart problem. From a things that we should have to do when we do cardiovascular examination, one of it is measuring the blood pressure. When we measure a blood pressure in children, we should have to select the correct BP cuff size. Width of the inflatable bladder of the cuff should be about 40% of the upper arm circumference. As you see on the image, the width of the inflatable part of the bladder of the cuff should be about 40% of the upper arm circumference, whereas the length of the inflatable bladder should be about 80% of the upper arm circumference. Cuffs that are too short or too narrow may give a false high reading, whereas a cuff that are too long or too wide give a false low reading. So we should have to use appropriate BP cuff size before measuring blood pressure in children. Normally, the systolic blood pressure in the legs is usually 10 to 20 mm of mercury higher than the upper extremity blood pressure or brachial artery pressure, and blood pressure readings that are lower in the legs are, as compared with the upper arms, are considered abnormal, and they should prompt a workup for a peripheral vascular disease. So a systolic pressure that is lower in the legs is than in the arms is abnormal. It might suggest some peripheral vascular disease, so it is abnormal, and we should have to work up in search of a possible underlying cause. But when we came to the diastolic blood pressure are normal in both upper and the lower extremities, whereas the systolic blood pressure is 10 to 20 mm of mercury higher in the lower extremities than that of the upper extremities. The other examination of the cardiovascular system is examination of the arteries. We should have to feel for pulses at the following site, as the carotid, brachial, radial, femoral, popliteal, dorsalis pedis, and anterior tibialis. And we should have to check the rhythm, the volume, and the character of the pulse, and also check for the synchrony of radial and femoral pulses to check for radiofemoral delay, which suggests a coarctation of aorta. So we should have to count the pulse rate when we count a pulse rate, if the rate is regular, we can count for a 50 second and they can multiply it by 4. Whereas if it is irregular, we should have to count a full minutes to get a pulse rate. When we say rhythm, we can say regular or regular, and irregular rhythms can be irregularly irregular, as in atrial fibrillation, or it can be regularly irregular, as in ectopic beats, or such as atrial or ventricular premature contraction. So, if a pulse is regular, we say a pulse is regular. If it is irregular, we should have to say whether it is irregularly regular or regularly irregular. Because each have its own differential diagnosis. So to narrow our differential diagnosis, if a pulse is irregular, we should have to classify whether it is regularly irregular or regularly irregular. And also we should have to check the volume. Is a pulse weak, or is it full in volume, or is a pulse not palpable? So this is important to identify whether the child is in shock, or whether the child is dehydrated, or whether the heart is not pumping well or not. And also we should have to feel for the radiofemoral delay. As you see on the lower picture, we should have to feel the pulse of the radial artery and the femoral artery. If there is a delay of femoral artery pulsation after that of the radial, there is a radiofemoral delay, and it might show, for example, coarctation of aorta. Those are peripheral arteries that we should have to examine. We should have to palpate the volume, the rhythm, and also character of a pulse at radial artery, ulnar artery, brachial artery, popliteal artery, femoral artery, posterior tibial artery, dorsalis pedis artery, and also carotid artery. When we should have to also look for abnormal pulses. When we say abnormal, there are different types of abnormal pulses. Looking for abnormal pulses will tell us some underlying problems. From this, the most common ones are, the first one is called pulsus bisferans. Pulsus bisferans is, it has a double impulse during systole. So if a pulse has a double impulse during systole, during a single systole, we call it pulsus bisferans. It might be due to aortic stenosis with insufficiency, or it might be due to severe aortic insufficiency. So when we feel a pulse, and if it has a double pulse during a single systole, we call it a pulsus bisferans, and it can be caused by concomitant presence of aortic stenosis with that of aortic regurgitation, or severe aortic regurgitation itself. The other is pulsus alterans. This is it is an alteration of the pulse amplitude on every other beat that is best felt at the radial artery. So if a pulse is strong first, then it is weak next, and if it alternates between weak and a strong pulse, we call it pulsus alterans. It signifies that not all the fibers of the myocardium are able to contract with each beat. So it causes alternating weakened strong pulses. For example, in dilated cardiomyopathy in aortic stenosis, we can feel pulsus alterans. The other is pulsus parvus. This is a low volume pulse, and it occurs due to shock, pericardial effusion, or myocarditis. The other is pulsus paradoxus. Pulsus paradoxus is due to the distension of the right atrium and right ventricle with venous return in inspiration. This causes compressing the left side of the heart and reducing its output. Or it is due to the reduction in pressure gradient between pulmonary vein and left atrium. So pulsus paradoxus occurs. Increased venous return to the right atrium and the right ventricle causes compression of the left side of the heart, and it causes reduced in cardiac output. This can occur in constrictive pericarditis and in severe asthma. The other is collapsing pulse. Collapsing pulse is high volume pulse with abrupt collapse and hammering at the fingertips and suddenly collapsing. And the most common cause of collapsing pulse is PDA and aortic insufficiency. The other is bounding pulse. It is a full exaggerated arterial pulsation, and it is due to vasodilation and increased cardiac output, exaggerated peripheral pulsation. It commonly occurs in thyrotoxicosis, fever, anemia, and aortic insufficiency. So if there is abnormal pulse, we should have to characterize the abnormal pulse. So characterizing the abnormal pulse helps us to narrow our differential diagnosis of the cause of the abnormal pulse. The next part of cardiovascular system examination is the examination of venous system. From the venous system, we should measure the internal jugular veins because the internal jugulars are in a direct communication with a right atrium. Systemic venous pressure is much lower than arterial pressure, and the venous pressure falls when left ventricular output or blood volume is significantly reduced. And it rises when the right heart fails or when increased pressure in the pericardial sac impedes the return of blood to the right atrium. Thus, venous pressure changes are reflected in the height of the venous column of the blood in the internal jugular veins, and it is termed as jugular venous pressure or JVP. So, examining for jugular venous pressure for engorgement of the neck vein includes, first we should have to, the patient should lie at an angle of 45 degrees and the face is turned to the left side, and look for venous pulsation medial to the sternocleidomastoid muscle on the right side, and identify the upper level of the pulsation, and identify also the sternal angle or angle of Lewis, and measure the height above the sternal angle. So first we should have to, the patient should have to lie at an angle of 45 degrees. Then the face of the patient should be turned to the left side, and look for venous pulsation medial to the sternocleidomastoid muscle on the right side, because the patient's face is turned to the left side, and identify the upper level of the pulsation, and also identify the sternal angle, and measure the height above the sternal angle by making 90 degrees to that of the point of the maximal pulsation. Sometimes the amplitude of the skin pulsation is small, and the following technique may help to bring up the jugular movement. Shine light tangentially from in front or behind the neck to make a shadow, and examine the slit hood of the neck for pulsation, and stand on the patient's left in order to obtain a good view of the slit heart of the skin overlying a right jugular vein. JVP must be measured for its height and the character of the waves, and the venous pulsation is not visible normally in this position. When the right arterial pressure is raised, neck veins are engorged and pulsations are visible. But if the engorged veins are not pulsatile, obstruction of the veins should be considered. And in small infants, it might not be possible to measure JVP at all because of the shortness of the neck. So it is difficult to measure JVP in small infants because their neck are so short. JVP must be differentiated from carotid pulsation. There are different techniques that we can use to differentiate carotid pulsation from that of internal jugular pulsation. From this, jugular veins are not palpable, or even when they are palpable, as in tricuspid speed insufficiency, they are comprehensible. But carotid pulsations are palpable and they are also not comprehensible. You do not make the pulsation to disappear by compressing it, but you can make the pulsation of the jugular vein. Jugular vein, they are most of the time they are not palpable, and if they are palpable, you can make it to disappear by compressing it. And supraclavicular pressure eliminates jugular pulsation, but supraclavicular pressure doesn't eliminate carotid pulsation. And inspiration increases amplitude of jugular pulsation, whereas inspiration have no effect on carotid pulsation. So it is important to differentiate jugular pulsation and internal jugular pulsation from that of carotid pulsation by using these techniques. Sternal angle is the reference point for JVP, and the level of sternal angle is about 5 cm above the level of the mid-right atrium in any position. So always in any position, mid-right atrium is 5 cm away from that of sternal angle. JVP is measured in any position in which the top of the column is seen easily. We can increase the angle above or down to make it visible to measure JVP, and the distance is the same whatever the position we use it. JVP measured at more than 4 cm above the sternal angle or more than 9 cm above the right atrium is considered elevated or abnormal. The other component of examining the venous system is examining the abdominojugular reflex or hepatojugular reflex test, and this is done by the palm of the examiner's hand is placed over the abdomen and firm pressure is applied for 10 seconds or more, and then when right heart function is impaired, the upper level of venous pulsation usually increases. And a positive abdominojugular test or a positive hepatojugular test is best defined as an increase in JVP during the 10 seconds of firm mid-abdominal compression, followed by a rapid drop in pressure of 4 cm after the release of the compression. And the most common cause of positive test is right-sided heart failure secondary to elevated left heart filling pressure. The other is examination of the precordium. For most of the cardiac examination, the patient should be supine in the supine position with the upper body raised by elevating the head of the bed or that of the table for about 30 degrees. And the two other positions are also needed sometimes, turning the patient to the left side and also leaning forward. The examiner should stand on the patient's right side always. Don't make a mistake by standing on the left side of the patient to examine the precordium. Always never forget that you should have to stand on the right side of the patient. Anatomical location of sounds in terms of interspaces and their distance from the mid-sternal or mid-clavicular line should be made. Identify the timing of impulse or sounds in relation to the cardiac cycle, whether it is systolic or diastolic, and also use palpation of either the carotid pulse or the apical pulse to guide the timing of your observation. Both occur in early systole right after the first heart sound. So, to know whether it is systolic or diastolic, we should have to compare the sound in relation to carotid pulse. We should have to palpate the carotid pulse, and if we hear the sound, abnormal sound, during the pulsation, it is during systolic. From inspection, palpation and auscultation of the precordium, let us start about inspection of the precordium. Inspect the precordium for abnormality in shape, identify the point of maximal impulse and other pulsation, and if there is a prominent vein, the direction of the flow should be determined. For example, in superior mediastinal mass, the blood flow from above downward, whereas in the inferior vena cava obstruction, blood flows from below upward. And also examine for any splinter, hemorrhage, spooning of the nails, and also other signs of cardiovascular problems such as clavity should be seen initially. Inspect for any deformity or pericordial bulge. Inspect for pericordial scar and also activity of the precordium. Should have to say active, hyperactive, or quiet. If there are two or more pulsation sites, we can say hyperactive pericordium. If it is only one, it is active pericordium, or quiet pericordium. A silent pericordium is when the patient is already died. So activity of the precordium should be described by active, hyperactive, or quiet. And also we should have to check for pericordial bulge. And apical impulse should be seen, and it is the most lateral and the most downward impulse. So apical impulse is the most lateral and the most downward impulse. And in most patients, apical impulse is a point of maximal impulse. But there is a certain situation in which apical impulses at different side of that of the maximal impulse. But most of the time, apical impulse is at a point of maximal impulse. Apical impulse is the most apical one, the most lateral and the most downward impulse, whereas maximal impulse is the point of the maximum pulsation that is visible. So they are different things. Point of maximal impulse is the point of maximal impulse that is seen, whereas apical impulse is the most lateral and the most downward impulse. Even though they are different, in most patients, apical impulse is a point of maximal impulse. And it should be expressed in terms of interspace for vertical location, and it should be described in distance from the mid-sternal line to the left side on the horizontal line. When we came to palpation, any tenderness over the pericordium, and also we should have to palpate the point of maximal impulse that we have seen during inspection, and we should have to also palpate for heart sounds. We should have to palpate S1 and S2, and also we should have to check whether P2 is accentuated, whether it is palpated or not, and also check for trill, and also check for Heaves. So point of palpating the point of maximal impulse, palpating heart sound, and checking for trills and Heaves are part of the palpation of the pericordium. These are the sites of the area where we found the earth sounds, and the right second interspace is called aortic area, and the left second interspace is called the pulmonic area, and the left sternal border right ventricle is right ventricular area, and the apical areas around left ventricular area. This is how we palpate the heart sound. This is the patient is, in this case, the patient is palpating the heart sound at the apex. When we say trill are a palpable or low frequency vibration associated with heart murmurs. So trill is a palpable murmur when we explain it easily. It feels like the throat of a purring cat, and they are always pathologic. Check for trills by pressing the ball of your hand firmly on the chest, and you should have to describe whether the trill, if there is a trill, you should have to describe whether it is systolic or diastolic by simultaneously palpating the carotid pulse or a point of maximal impulse. So to say whether the trill is systolic or dystolic, we should have to concomitantly palpate carotid pulse or apical pulse. If the trill occurs during carotid pulsation, it is systolic, otherwise it is diastolic, and the site should be labeled at apex, at the left lower sternal border, at the base of the heart. So you can say there is a systolic trill at the apical area, or diastolic trill at the base of the heart, or like that. We should have to describe the timing of the trill, and also we should have to describe the site. And apical trills can be easily felt with the patient rolled over to the left side or the left lateral position. When we come to Heaves, parasternal lift or heave or apical heaves, it is a closely observe the movement of your fingers or thumb while putting your hand on the left sternal or apical area. A left parasternal lift is frequently present in patients with severe mitral regurgitation, and it's due to anterior displacement of the right ventricle by an enlarged expanded left atrium. So apical heaves is most of the time due to left ventricular hypertrophy, whereas epigastric pulsation is due to right ventricular enlargement. Whereas apical systolic trill is most of the time due to mitral insufficiency, whereas diastolic trill at the apex is due to mitral stenosis or tricuspid stenosis. And right lower sternal border trill is most of the time due to ventricular septal defect, and like that. When we came to the auscultation part of the cardiovascular system examination, auscultating for the normal heart sound S1, S2, and also auscultating for any extra sound such as S3 and S4, and also for any possible murmurs, pericardial friction rap should be done. We should have to need to recognize the normal to detect the abnormal. So to identify the abnormal, we should have to recognize the normal, and the room should be quiet. And auscultate at each valvular area, as we have said, aortic area, pulmonic area, mitral area, and tricuspid area should be auscultated, and the base of the heart, and also at the apex and at the left lower sternal border. And also possible findings such as accentuated heart sound, muffled heart sound, normal heart sound should be first of all, we should have to know our stethoscope, and our stethoscope have two parts, the bell part and the diaphragm part. Each part has its own function. So if you don't use both sides during cardiovascular, especially pericordial auscultation, it is wrong. So we should have to use both sides as needed. The diaphragm is better for picking up a relatively high-pitched sounds. So high-pitched sounds are most of the time it is picked by diaphragm, such as S1 and S2, and also murmurs of aortic and mitral regurgitation and the precordial friction rap. Those things are heard by diaphragm and listens throughout the precordium with the diaphragm and pressing it firmly against the chest. Whereas the bell is used for more sensitive for a low-pitched sounds such as S3 and S4 gallop, and also the murmur of mitral stenosis, and apply the bell lightly. We should have to apply the diaphragm firmly, whereas we should have to apply the bell lightly, and use the bell at the apex, then move medially along the lower sternal border. So the bell is used for detecting low-pitched sounds such as S3 and S4 gallop and also murmur of mitral stenosis, whereas the diaphragm is used to detect relatively high-pitched sound, and we should have to place it firmly, and it is used to detect, characterize S1 and S2, and also to identify the murmurs of aortic and mitral regurgitation and also pericardial failure. Listen for heart sounds. The timing of the heart sound or murmur can be determined accurately from its relation to other observable events in the cardiac cycle, the carotid arterial pulse, the apical impulse, and the like. Normally, we should have first of all we should have to listen for S1, and then for S2, we should have to know their intensity, their rhythm, their variation with breathing. S1 is produced by the closure of atrioventricular valve, and it is loudest at the apex. Always S1 is loud at the apex, whereas S2 is loud at the base. S1 is produced by the closure of the AV valves, and it's loudest at the apex, and S2 is composed of sounds produced by the closure of aortic and the pulmonic valves, and it might be split narrowly. S2 is heard well at the base, and it might split narrowly, and the gap in split might change with respiration. But if it is not changing with respiration, it can be fixed split, which may occur in a disorder like atrial septal defect, or it is widely split S2, such as in pulmonic stenosis, or paradoxical splitting, which is wider split during expiration than inspiration. And paradoxical splitting or splitting during expiration it can occur in PDA or aortic stenosis. And also we should have to auscultate for extra sounds such as S3 and S4, and also opening snap during systole and during diastole. S1 comes with apical impulse or upstroke of the carotid pulse, and the first and second heart sounds are, as we have said, it's primarily by the closure of a valve and the seminal valves and the event that accompany the squares. Extra heart sounds. S4 is, it is in adult most of the time S4 is physiologic, whereas in pediatrics most of the time it is pathologic S4, and pathologic S4 is due to atrial gallop, and it is best heard at the apex. So S4 is atrial gallop, and most of the time we hear at the apex, whereas S3 is it is a ventricular sound, and it is a ventricular gallop. So S3 is a ventricular gallop, whereas S4 is atrial gallop. S3 is a ventricular gallop. It is best heard at the apex and also at the lower sternal border, and it might be physiologic in children. To differentiate whether S3 is physiologic or pathologic, physiologic S3 disappears when the patient sits up, and the pathologic S3 or ventricular gallop persists when the patient sits up, and it indicates decreased ventricular compliance. So physiologic S3, it disappears when the patient sits, whereas pathologic S3, it persists whether the patient sits or in the supine position, and it is a ventricular gallop, and it is caused by decreased ventricular compliance. When we came to heart murmur, if we detect a murmur, we have to describe its timing, its shape, its location, its radiation, its intensity, its pitch, and also its quality. When we say timing, the timing of murmur can be systolic or diastolic. Systolic murmur it falls between S1 and S2, while a diastolic murmur falls between S2 and S1. Palpating the carotid pulse as you listen can help you with timing. And the murmurs that coincides with carotid upstroke are systolic, as we have said. And systolic murmurs are usually mid-systolic or pansystolic. For example, aortic stenosis, pulmonary stenosis, they are mid-systolic, whereas mitral regurgitation, tricuspid regurgitations are pansystolic or holosystolic. Mitral valve prolapse most of the time it is late systolic. So when we hear a murmur, we should have to time it, whether it is systolic or diastolic, and specifically whether it is mid-systolic, mid-diastolic, or late systolic or pansystolic, we should have to explain it very well. Diastolic murmurs may be early diastolic, mid-diastolic, and late diastolic as that of systolic murmur. Early diastolic murmur can occur in aortic regurgitation, pulmonary regurgitation, and the mid-diastolic murmur is most of the time due to mitral stenosis. Occasionally, a murmur can start in a systole and it continues without pause throughout S2 into, but not necessarily throughout diastole, and it's called continuous murmur. For example, patent ductus arteriosus causes a continuous murmur. We should have to also explain the shape of the murmur, such as a crescendo murmur. A crescendo murmur is it grows louder. For example, mitral stenosis causes a crescendo diastolic murmur. A crescendo mid-diastolic murmur is mitral stenosis. The murmur grows louder. A decrescendo murmur, it grows softer. This is most of the time decrescendo murmur is due to aortic regurgitation. So aortic regurgitation causes early diastolic decrescendo murmur. A crescendo murmur is a murmur that first rises in intensity, then a murmur that then grows softer. For example, in a hypertrophic cardiomyopathy, it is a decrescendo murmur. So the shape of the murmur should be described, and a Pluto murmur has the same intensity throughout it. For example, mitral regurgitation. Mitral regurgitation is a systolic murmur, and it is a Pluto type of murmur. The intensity is the same throughout the murmur. The other is the location of the maximal intensity should be described, determined by the site where the murmur originates, and describe where you hear it best in terms of the interspace and its relation to the sternum and the apex or the mid-sternal line or the mid-clavicular line. For example, a murmur best heard in the second right interspace usually originates at or near the aortic valve, whereas a murmur of mitral origin usually is best heard at the apex. So location is very important. The other is radiation. It is a transmission from the point of maximal intensity. This reflects not only the site of origin, but also the intensity of the murmur and the direction of the blade flow. So the direction of radiation is the direction in which the blade that flows through that valve goes. Explore the area around the murmur and determine where else you can hear it. For example, a loud murmur of aortic stenosis often radiates into the neck in the direction of arterial flow, whereas a murmur of mitral regurgitation radiates to the axilla, especially to the left axilla. We should have to also intensify or grade the murmur. We grade into 6. Grade 1 murmur is very faint and it is barely audible in quiet room. And grade 2 is it is quiet, but it is heard immediately after placing the stethoscope on the chest. So grade 2 murmur is audible, whereas grade 3 is moderately loud. Grade 4 is a loud murmur with palpable trill, whereas grade 5 is a very loud with trill and it might be heard when the stethoscope is partly off the chest, whereas grade 6 is very loud with trill and it might be heard with stethoscope entirely off the chest. So if there is to grade a murmur, we should have to check a trill first during the palpation part. So without examining a trill, we can't grade a murmur. The other is quality of the murmur. This is described in terms such as blowing, harsh, rumbling, and musical sounds. Pericardial friction rab is it is a grating or scratching sounds associated with each beat due to the movement on each other of the pericardial layers, and it is best heard at the base of the heart, and it has no relationship with respiration. The intensity can be increased by leaning the patient forward, and it might occur in TB pericarditis and also in acute rheumatic fever. And also sometimes mediastinal crunch or Hamann sign can be seen, and this is a crashing sound produced when there is air in the mediastina, and the patient may feel the sound by himself. Overall, when we came to the summary of the cardiovascular system examination, cardiovascular system includes examination of the arterial system, measuring the blood pressure, and also measuring the jugular venous pressure, and also the precordium, and some peripheral signs of heart disease. Examination should be in a quiet room and observe for clubbing, cyanosis, or signs of anemia, and assess the blood pressure, pulse, specifically in pulse rate, rhythm, and volume, and at radial pulse, and also we should have to palpate other peripheral arteries and check for all accessible peripheral arteries whether they are symmetrically palpable or not, or whether any radiofemoral delay is there, and also check for JVP whether it is raised or not. When we came to precordial examination, on inspection, check for precordial bulge, check for scar, check for apical impulse, and the point of maximal impulse, and also the activity of the precordium, whether it's active, hyperactive, or quiet. And on palpation, check for head sounds and the point of maximal impulse, specify location, diameter, amplitude, and the duration. And check for thrill. On thrill, check for the site and the timing. The site of the thrill and whether it is diastolic or systolic. And also parasternal heaves should be checked during palpation. During auscultation, normal heart sound should be heard. S1 is well heard at the apex and S2 is well heard at the base, and sometimes S3 and S4 gallopes can be heard. S3 gallopes, it is a ventricular sound, and the S4 is it is atrial gallop. And there is physiologic S3, and the physiologic S3 and the pathologic S3 are differentiated by making a patient to sit. If it disappears when the patient sits, it is a physiologic S3. And the murmur should be also checked for the timing, shape, location of the maximum intensity, radiation intensity, and quality. This is all about cardiovascular system examination. Please put your comment or suggestion at the bottom. Thank you.